We're now going to talk about mood disorders. Mood disorders are comprised of major depressive episodes, hypomanic episodes, and manic episodes. And so the first part, we're going to define these episodes. Now, I want to stand back for a minute and discuss the evolutionary theory of why we have moods. So sadness and grief occur when we've been disappointed or we lost something or we've been defeated. That leads us to avoid future problems in a negative feedback loop. It also motivates individuals to seek social support, and it permits an individual to withdraw in order to conserve resources. There's no point of putting in lots of energy when you're just going to lose again. Joy and grandiosity, on the other hand, are a response to success. They reinforce behavior that enhances survival. They promote creative and goal-directed pursuits. They encourage risk-taking, which is necessary for selective advantage of social groups. And there's increased sexual behavior that leads to increased offspring. So natural selection explains why these emotions have been embedded in our brain for hundreds of thousands of years. Now let's look now at the lifetime prevalence of mood disorders. So here we have three different studies during a different time looking at the epidemiology of the various mood disorders. Dysthymic disorder is just a chronic, smoldering, low-level depression. And you've got unipolar and then bipolar disorders. So what do you see here? You see that the prevalence in the 1980s was a little over 6% in terms of 8% in terms of depressive disorders, and only 1.3% in bipolar disorders. And you go all the way to the last decade, you see a similar pattern where the prevalence of lifetime prevalence of depression far outweighs the lifetime prevalence of bipolar disorders. And when you think about evolutionary theory or natural selection, what we're basically seeing that our brains have been skewed over to the depressive side of things, with only a few individuals getting the hypomanic or manic episodes that are necessary to advance the successes of social groups. So we're essentially a depressive species. So we talked about mental status exam already, but I wanted to review the difference between mood and affect. So in the mental status exam, when we describe mood, we may say that we ask the patient, hey, what's your mood? And they say, well, I'm sad. And so you would say the mood is, and in quotes you say, the mood is sad. Or what I do often is I do what the inferred, when I'm talking to the patient, what I infer their mood must be as it appears to me. And you can do either one, or you can do one and the other one. So affect, however, describes the range of mood, the intensity, whether it's appropriate to the content of the interview, and when is it congruent with the mood that the patient states they are experiencing. So examples of mood, there can be euphoria, expansiveness, irritability, euthymia, which means that it's a completely normal mood, neutral, dysphoric, or anxious. Affect can be described as labile, which means that the mood is fluctuating, where the person may seem laughing, overjoyed, and the next minute incredibly irritable or sad and crying. Affect can be full range, which is what we consider normal. The person seems kind of in a cheerful state when describing things that are make them happy, and when discussing things that make them sad, they can actually change their composure to look as if they're sad. Restricted, blunted, and flat show the range being constricted. So a person who is depressed and is only demonstrating a depressive mood would be restricted. A person whose mood is becoming almost impossible to tell because they're just flat, will be blunted or flat. Appropriate or inappropriate, incongruent and incongruent are other descriptors for affect. So when does a mood disturbance become pathological? When the person's reaction is disproportionate to the precipitant, if the duration of the sadness lasts longer than what would be expected, if it does not respond to feedback from others, if it's pervasive and unrelenting, and if it impairs judgment and behavior. So there are diagnostic criteria in the DSM that are used to delineate the ups and the downs versus a disturbance in mood. And there are two broad disturbances. There's depression and mania. Mood disorders are different than mood episodes. The mood disorders involve diseases whose symptoms are characterized by depressive or manic episodes or a combination of these different mood disturbances. That's a difficult concept, but we'll be reinforcing it throughout the lectures. So a major depressive episode consists of either depressed mood or anhedonia, which is anhedonia is a diminished interest or pleasure, plus 4 of the other criteria. So interestingly, the person with depression can have a decreased appetite or an increased appetite. Patient may have insomnia, or they may be sleeping 12 hours a day. So there can be opposite manifestations for appetite and sleep. Psychomotor agitation or retardation is when the person looks as if they're either agitated or they look like they're barely moving at all. A pervasive loss of energy and fatigue. People will have low self-esteem or they'll feel excessive guilt. They have problem concentrating and making decisions, and they may have recurrent thoughts of death or even suicide. So you need 1 in the yellow and 4 in the others. So for a major depressive episode, the symptoms cannot be due to another medical condition or to a substance like a drug. There has to be clinically significant distress, and there's got to be some impairment. We don't call things a disorder unless there's distress or impairment. The symptoms have to be for most of the day, nearly every day, for at least 2 weeks. Okay, they had to decide some duration, and the authors of the DSM decided that 2 consecutive weeks of depressed mood would qualify as a major depressive episode, and that it would respond to treatment. Now, one concept is that regardless of what the stressor is, if the person meets these criteria, they are considered having a depressive episode, a major depressive episode. And people say, well, what about a significant loss, bankruptcy, bereavement after a loved one has died, or serious medical illness? In those cases, a person can be intensely sad, they can ruminate, they have insomnia, poor appetite, and that may resemble a depressive episode. Although they may be understandable and considered appropriate to the loss, the presence of a major depressive episode should still be carefully considered. This is where you have an exercise of clinical judgment. The important thing is to err on the side of actually labeling the person with a major depressive episode. Why? Because a major depressive episode can be dangerous, and a major depressive episode can respond to either medication or psychotherapy. It doesn't have to be medication, it can be counseling. But what we don't want is clinicians dismissing the patient's symptoms because the physician says, well, if I lost my wife, I'd feel that way too. That's a dangerous position for a physician to take, given the risk of complications such as suicide, which, by the way, is the 10th largest cause of death in the United States. Now, for decades, medical students have learned the criteria for a major depressive episode through mnemonics. So one mnemonic is sad A faces, problems with sleep, appetite. The dysphoria and the anhedonia are in yellow because you need 1 or 2 of those to meet the criteria. And then you've got the other criteria listed as well. The more common mnemonic is SIGI CAPS. So sleep, interest, guilt, energy, concentration, appetite disturbance, psychomotor agitation and retardation, and suicidal ideation. And this is the one you'll hear over and over again that people will use. In fact, it's so common that when writing a note or presenting the case, you may say, patient meets the SIGI CAPS criteria. But there are other symptoms of depression. A person may describe frequent crying spells, feeling helpless or hopeless. Irritability and aggressiveness are particularly found in men who are depressed, but can also be found in women. 60% of people with a major depressive episode also have concomitant anxiety, which can be crippling. Somatic symptoms, well, we know fatigue and psychomotor retardation or agitation can be found in depression, but you also find symptoms of pain, alterations in bowel movements, any kind of GI upset or dyspepsia, joint pain, myalgias, etc. People with depression will also describe lack of sexual interest, or it can be even lack of arousal or inability to achieve orgasm. Some people with depression neglect their appearance, and they may look disheveled when they come into the office. And there are severe forms of major depression where a person will have hallucinations and or delusions, and we call that a psychotic depression. So one of the most common screening tools that are used in primary care is a tool called the PHQ-9, the Patient Health Questionnaire, PHQ-9. And you'll see this is administered to patients, and they then rate themselves according to all these criteria. You basically have the 9 symptoms of depression, and as you look at the columns, the patient will say, well, several days in the past 2 weeks, more than half the days, and nearly every day. The more depressed they are, the more they're going to congregate towards the 2 and the 3, and when you add them up, you actually get a number that can tell you how severe the depression is, and this can also be used to follow the patient's response to treatment. So a person gets a 5 to 9 as a score, it's mild symptoms. If it's 10 to 14, they have minor depression or a mild major depression. At which point you can think about psychotherapy or watchful waiting. But as the depression is more severe, you get these higher numbers, and intervention becomes more and more important, either with psychotherapy or medication or both. Okay, so now we're going to look at a case of major depressive episode.
Mrs. Houston, please tell me why you came to the hospital.
My marriage broke apart.
When was this?
My marriage? 6 months ago.
How long were you married? How'd the breakup affect you?
I moved to an apartment by myself in another town.
How's that been for you?
Terrible. I don't feel like meeting new people.
Meeting new people?
They're busy and want to do things. I don't feel like going out. I just want to stay close by.
Close by to?
Things in the apartment.
Tell me about something in your apartment.
Like what?
Anything. Describe one thing from your apartment.
Um,
What's the first thing you think of?
my bed.
What do you call your husband?
Robert. He's never coming back. And my son, he left. He got a job in San Diego, 3,000 miles away. I can't afford to visit him.
How often do you see your son?
He lived with me until last week. But my worrying about Robert drove him away. And my back pain. I tried not to complain, but
Mrs. Houston, what are you feeling now?
empty, lost. There's nothing left.
Have you thought about hurting yourself or taking your life? How would you do that?
Pills.
What about pills?
Sunday morning. I didn't go to church. I took all my pills. There was no way anything was going to change.
What happened?
My neighbor, Mrs. Laughlin, found me. We sit together at church. She came by the apartment to check on me and called an ambulance.
How'd you feel about that?
She should have let me die. Everyone would have been better off.
To whom do you feel you're a burden?
My son. My father, maybe.
Your father?
He worked so hard to give me a better life, and I threw it all away. I'm sorry. I'm sorry.
Tell me about your father.
When I was a little girl, he had a dream. When I was 4 or 5.
So let's describe the mental status exam of that woman who we just saw. Her appearance, her hair is slightly disheveled. She's not wearing makeup. You see some degree of self-neglect. Her attitude and behavior, well, she's cooperative, but she makes very poor eye contact. She's tearful. And you notice there's not much movement. She does have psychomotor retardation. Her speech is slow. There's even some latency of speech. There's a pause after the interviewer asks her some questions. She pauses for a while. We call that latency of speech. Well, her mood is clearly depressed, and she has a constricted affect, meaning her mood is at a very narrow band, and we would call that constricted. It's not flat. Flat would be no emotional expression at all. But she does have expression. It's just very restricted to the depressed range. And it's appropriate to the content. Um, she talks about her husband having left her, and that would assumingly make many people sad and are upset. Her thought process is linear. There is some thought blocking. There is a point in which the interviewer asks her a question, and she has a very prolonged pause and then says, "Can you ask that question again?" That's an example of thought blocking, losing the train of thought mid-sentence. Thought content. She's preoccupied with feelings of guilt, worthless, and she also has plenty of physical complaints. She does have suicidality with the idea to overdose, and she intended to overdose. In fact, she almost succeeded had her friend not knocked on the door at the time. She was not asked about homicidal ideation, hallucinations, or delusions, but she should be asked about those things. Remember, every time you describe thought content, you have to include suicidality, violence, hallucinations, and delusions. That must be always asked about and documented under thought content. Her insight is fair. She's certainly aware she's depressed, but her judgment is poor. Instead of seeking help and seeking treatment, she thinks about killing herself.